say, a great pleasure to be here today to talk about new antibiotics and their use. I'm told that nowadays I should always start with a disclosure slide. As has been said, I continue to do some consulting for the medical and device industry, although I'm substantially retired now. Bit of consulting, occasional lectures. I have a few shares in different companies, and despite this glorious history, I'm not entirely popular with the UK government for having spoken out against the use of COVID vaccines, particularly in children during the recent pandemic, though I see that even America has now stopped advocating COVID vaccines for children. But let's steer clear of COVID for the afternoon and talk about antibiotics. We went through a long period in the late 1990s and the first decade of this century when there were very few new antibiotics launched that had any activity against gram-negatives. Yes, new anti-MRSA agents came, new pneumococcal agents, but nothing very much against gram-negatives. That's now changing, and over the past 10 years, we've seen the launch, and it obviously varies somewhat between countries, but internationally, we've seen the launch now of 6 new beta-lactamase inhibitor combinations, a new tetracycline, a ribociclib, a catechol cephalosporin, cafidrocol, and in a few countries, a new aminoglycoside, plazomicin. More are coming: cefepime zidibactam, cefepime nacabactam, cefepime taniborbactam. We're soon going to have lots of different combinations with cefepime to create great confusion, I fear, among the unwary. But what I'm going to try to argue through this presentation, that these are very much horses for courses. And you can see it on the slide. Some are active against Enterobacterales with one resistance type, but not Pseudomonas with another resistance type. And really, one needs quite a close knowledge of horses for courses. So let's try to break this list down somewhat. There's 2 combinations there that use penicillinic acid sulfones, so N-metazobactam and ceftolozane with tazobactam. Now, everybody's familiar with tazobactam. It's been combined with piperacillin for at least 25, if not 30 years now. N-metazobactam's less familiar, but it's a modification of tazobactam with an additional methyl group added. It's pharmacodynamically rather better. It's like a longer half-life, and it's got a rather stronger inhibitory activity to tazobactam, though a fundamentally similar one. It's been put with cefepime. Now, the point there is that cefepime is an easier compound to protect than, say, piperacillin. Cepepime's more stable, particularly to AMP-C beta-lactamases. So you're looking here, cefepime and tazobactam, we'll see in a moment, a very broad spectrum of activity. Also, whereas piperacillin tazobactam often isn't active against ESBL producers, that's not owing to a failure to inhibit the ESBL. It's because they've often also got OXA1, which is a penicillinase, which isn't inhibited by tazobactam. Well, cefepime's stable to it, so it doesn't matter. And then cefepime and tazobactam may, and I stress the word may, also have some activity against OXA48 producers, but there's scant clinical evidence as yet. Pseudomonas I'll come back to. But there you see the data. Now, these are Europe. These are Enterobacterales, resistant to 3rd generation cephalosporins. Very few of them have got carbapenemases, but almost all of them have got an ESBL or an AMP-C. Orange bars cefepime alone, lighter orange is piptazole. but blue is cefepime enmetazobactam, showing almost as good as ceftazidime avibactam. So this is a new option coming against problem Enterobacterales. Questionable if there's a carbapenemase, but for the commoner garden ESBL C producer, a lot more potent than piptazole. Ceftolozane, not as easy to protect as cefepime. It's not stable to AMP-C, and it's been put with tazobactam, that older, less potent inhibitor. But where it's interesting is Pseudomonas. Now, these are Pseudomonas sent to the UK National Reference Laboratory, percent susceptibility. Now, if you look at the older beta-lactams, piptazole or ceftazidime, well, if there's a high level AMP-C enzyme, 80% are resistant. If there's upregulated efflux, well, depends how strongly it's upregulated, but anywhere up to 73% resistance. Ceftolozane tazo keeping activity against these groups. Once there's an exotic beta-lactamase like an MBL or even an ESBL, and they're mostly Veb types in Pseudomonas, then it falls over. But these are rarer than upregulated efflux and AMP-C. And that follows through clinically. Here's a nice little study from Barcelona in Spain, 38 cases, very multi-resistant Pseudomonas, susceptible though to ceftolozane tazo, MICs between 1 and 4 mg per litre, treated with ceftolozane tazo, usually at high dose. Frankly, for bugs like this, it should always be high dose. And 86%, 87% clinical response. That's pretty good for such multi-resistant, difficult Pseudomonas in patients where, a third of them were bacteremic. But in several cases, whoops, we've gone over, 4 cases, there was emergence of resistance. And that was usually a sequence change in the AMP-C beta-lactamase, making it a better ceftolozanase. So what I'd say about these inhibitor combinations, cefepime and enmetazobactam, good against ESBL and AMP-C Enterobacterales. It's going to be more expensive for the time being, but perhaps we should see it as the future workhorse replacing piptazole. Ceftolozane tazo, anti-Pseudomonas drug, good one. I don't see much role outside Pseudomonas. Let's come to the non-sulfone inhibitors now. They're mostly diazobicyclooctanes. So we've got ceftazidime with avibactam, now also aztreonam with avibactam, imipenem with relebactam. Those are all related inhibitors. They're diazobicyclooctanes. Then meropenem with a completely different inhibitor, a boronate called vaborbactam. Now, here's ceftazidime avibactam, which has been about for the longest of these. This is in the United States, looking at carbapenemase positive Enterobacterales. Clinical outcomes. And because it's the United States, then it's almost all KPC carbapenemases. Avibactam inhibits KPC carbapenemases really very well. And if you look at deaths in hospital, this is experience rather than randomized trial, but lower death rate than with the previously used colistin combination and more discharged home. And this is the sort of result that's been replicated elsewhere, that this combination of ceftazidime with avibactam comes out better against KPC Enterobacterales than the previously used colistin combinations. Against OXA48 producers, Well, ceftazidime is actually stable to OXA48, but many of the isolates with OXA48 have also got the ESBLs. So what's happening here is the avibactam's inhibiting the ESBL. The OXA48 can't attack the ceftazidime, so the ceftazidime can then get to work against the bacteria. These are OXA48 producers in Spain. Very difficult patients. Look at those Apache scores, an average of 24. 54% of these patients were septic, extremely multi-resistant. They receive ceftazidime avibactam. 49 out of 57 survive, including 80% survival where the ceftazidime avibactam was given as monotherapy. So, ceftazidime avibactam, no possible doubt, a good option against producers of KPC and OXA48 type carbapenemases. But avibactam won't inhibit a metallocarbapenemase, and a metallocarbapenemase will attack ceftazidime. And that's the rationale between developing now aztreonam with avibactam. Avibactam doesn't inhibit metallocarbapenemases, I've just said, but aztreonam is stable to them. So the logic is avibactam will inhibit every other beta-lactamase, avibactam stable to the MBL, so the combination of aztreonam avibactam is very active against virtually all Enterobacterales with carbapenemases. Doesn't matter if they're KPC types or OXA48 types, or whether they're even metallotypes. Clinical results are starting to dribble through, and Pfizer have published 2 relevant clinical trials, Revisit and Assemble. Now, Revisit's peculiar. It's a mixture of pneumonias and intra-abdominal. In general, aztreonam avibactam against multi-resistant pathogens. In general, aztreonam avibactam with metronidazole performed as well as meropenem with or without colistin. However, once you get down to the MBL producers, the critical ones, this combination, only 2 out of 7 good outcomes, and 2 out of 3 for the meropenem with or without colistin. So tiny numbers are not impressive. This was supposed to be a bigger trial, but against MBL producers specifically, but recruitment was messed up by the pandemic. They only recruited 12 patients. Aztreonam avibactam cures in 5 of 12 MBL producers, as against 0 of 3 in best available therapy. So one has to say some positive pointers, but tiny numbers of patients. We need a lot more experience here. That's a concern. Here's another concern going back to ceftazidime avibactam. These are consecutive patients with carbapenem-resistant Enterobacterales. The huge majority, 27 out of 37, with KPC carbapenemases at University of Pittsburgh. Diverse infections, good overall cure rate, but 3 out of the 27 cases, there's emergence of resistance through mutation to the sequence of the KPC carbapenemase. And that's a mode of emerging resistance that's turned up worldwide. Not yet common, but scattered. It is a concern. Turn now to meropenem with avibactam. This avibactam will only inhibit KPC carbapenemases. If your Klebsiella or whatever's got a KPC carbapenemase, meropenem avibactam's an option. If it's got OXA48 or a metallo, it isn't. They did a nice little clinical trial against KPC Enterobacterales, against best available therapy, which was usually a colistin combination. And really, however you cut the data, it came up in favour of meropenem avibactam. Emerging resistance has been less of an issue than with ceftazidime avibactam, but the drug's been less used, and there have been odd reports through reduced permeability. Next one to talk of, in fact, the last of these inhibitor combinations, imipenem with relebactam. They did a big trial in hospital-acquired pneumonia, ventilator pneumonia, but most of those weren't terribly resistant isolates. So again, I've just put up the resistant isolates trial. These were imipenem-resistant infections, most of them, or at least half of them, due to Pseudomonas with impermeability type resistance. Now, it sounds mad to use a beta-lactamase inhibitor combination against bugs with impermeability type resistance. However, in Pseudomonas, that impermeability type resistance also requires the chromosomal AMP-C enzyme. And if you inhibit that, then the permeability alone won't give the resistance. So they got decent results, 13 out of 16 positive results with these imipenem resistant Pseudomonas, as against 5 out of 8 with imipenem cuscolistin, which give a lot more toxicity. Among this tiny trial, there were only 4 patients with KPC with carbapenemase producing Enterobacterales. They all had KPC Klebsiella, and only 1 out of 4 of them had a good result. Now, as with the aztreonam avibactam and metallocarbapenemase producers, it's tiny, it may be bad luck, it ought to be active, but more experience is needed. Lastly, let me move away from beta-lactamase inhibitor combinations. I'm not going to say any more about plasmamycin, except that where a bug has got an NDM carbapenemase, as May has already said, that's often on a plasmid that also encodes a ribosomal methyltransferase, which modifies the ribosomes so that they won't bind any aminoglycoside, including plasmamycin. So that's a bit of a problem, particularly in the Middle East and India, where one has so much NDM carbapenemase, as I say, accompanied by methyltransferases. But the other two, cafidrocol and eravacycline. Cafidrocol is actually the broadest spectrum of all these new antibiotics that I've spoken of today. It's a catechol cephalosporin. What that means is it's got this group here, a benzene ring with 2 adjacent hydroxyls. That's a catechol. That binds iron. Bacteria are scavenging for iron all the time. They use catechols themselves, and they mistake this complexed with iron for their normal iron scavengers, and they actively bring it into the cell where, bingo, it binds to the penicillin binding proteins and poisons the bacteria. Shionogi, credit to them, did a big resistant pathogens trial. However, it didn't turn out as well as one might have hoped. This is survival probability, a Kaplan-Meier plot. Cafidrocol's the solid line, best available therapy is the dashed line. And as you see, the cafidrocol didn't do as well in terms of survival as the so-called best available therapy. Now that was largely down to carbapenem resistant Acinetobacters. If you look at the other groups, the Klebsiellas and the Pseudomonas were actually against Klebsiella. Cafidrocol was doing better than best available therapy. Pseudomonas, the numbers are tiny, it's not statistically significant. The problem with Acinetobacter. So against Enterobacterales and Pseudomonas, I would not be put off by that credible trial. I would be cautious with regard to Acinetobacter. Here are the metallocarbapenemase producers, and one has to say that these look better than the results I just showed you for aztreonam avibactam. So this is again from credible CR, clinical cure, microbiological eradication, cafidrocol against best available therapy. And you're looking at 60s, 70% there, at least for clinical cure. Less good, inevitably, for microbiological eradication. Again, though, in that trial, and this made part of the issue with Acinetobacter, some emergence of resistance. MICs going up from 1/4 or 1 mg per litre to 4 or 8 mg per litre. And as I say, the problems in credible trial mostly associated with poorer outcomes for Acinetobacter. And here I think's the clue, some emergence of resistance. As I've said, better results though with Enterobacterales, but even here, some emergence of resistance during cafidrocol therapy. This isn't in the clinical trial. This is a later clinical case. There have been others reported. This was an Enterobacter cloacae, but it's seen also with Klebsiella. Remember, this drug requires the ion transporters to get into the bacteria. Bugs can switch between different types of ion uptake mechanism. This is what's happened here. A catechol receptor, SIR-A, has been inactivated during treatment, and the MIC going up from 1 mg per litre to sky high. Where to prefer cafidrocol then? Well, I do think it's the drug of choice against MBL producing Enterobacterales. Aztreonam avibactam may displace it, but we need more data, and certainly against MBL producing Pseudomonas. Also Pseudomonas that have got extended spectrum beta-lactamases. Remember how resistant they were to ceftolozane tazobactam. Final drug to mention, eravacycline. We finally left the beta-lactams. We've got a tetracycline. This one's simple to summarise. It's like tigecycline, which you're all familiar with, but it's got better pharmacodynamics. Higher dosage, get a bit higher level, the MICs are a tube lower than tigecycline, and there's less gastrointestinal disturbance. Unfortunately, the data are limited. Successful trial in intra-abdominal infections, or rather 2 successful trials, 2 failed trials in complicated urinary tract infections, probably because it's largely got biliary excretion. This was a crazy setting in which ever to do a trial with a tetracycline. My view would be that you should consider it where you're considering tigecycline. At the very least, you're less likely to make your patient nauseous. So let me finish by repeating what I said at the start. We are looking at new drugs against gram-negatives. Some of them are really very promising, but none of them is a universal panacea for problem gram-negatives. It's horses for courses. Ceftolozane tazobactam, and based on what data we have at present, imipenem relebactam, I would see as drugs against problem Pseudomonas. Maybe that imipenem relebactam is an option against KPC Enterobacterales as well, but we need more data. Cefepime and met-tazobactam, future workhorse replacement for piptazil. Maybe a partial answer against OXA48, but more data needed. Ceftazidime avibactam, good provenance now against KPC and OXA48 Enterobacterales, but some risk of emerging resistance with KPC. Aztreonam avibactam, broader spectrum than ceftazidime avibactam against carbapenemase producing Enterobacterales. In vitro, it includes MBL producers, but the early clinical data against MBL producers are underwhelming. More data needed. Meropenem-Vapobacter, good option against KPC enterobacterales, but no interest for anything else. Cefidrochol, good option against MBL producing enterobacterales, regardless of beta-lactamase type and Pseudomonas. Be careful with Acinetobacter. Ivericycline, think about it while you're presently thinking about tigecycline. Overall, I do think that with these new options, there's less role for colistin. It doesn't have outstandingly good outcomes. It's often been the best available therapy base in the trials I've talked of, and it doesn't have a good toxicity profile. Sorry if I've gone a moment over. I hope you found it interesting. Thank you.